So moving on from then, we're going to talk about abdominal hysterectomy. And in the United States, at least, this has traditionally been the most common approach, although in more recent years we've seen an upswing in laparoscopic and robotic hysterectomies, which are slowly decreasing the numbers of abdominal cases that are performed. This is often done in cases of malignancy. I mentioned earlier that hysterectomies, salpingo-oophorectomies are part of the staging for gynecologic cancer. Other cases you might consider this is if there's a particularly large uterus. Those of you who read in the journals and newspapers in 2013 and 2014, there's been a lot of questions about the safety of morcellation. That's a topic for another day, but morcellation involves the cutting of the specimen, the uterus, to be removed into much smaller pieces so they can be extracted either laparoscopically or through a small incision. And in some cases, this may add to the risk of the procedure. If the disease you're treating is known to be a malignancy, then morcellation is contraindicated. And you have to think twice about doing it in cases of even suspected malignancy or possible malignancy, because there can be an additional risk of spread of the cancer. And like I said, in 2014, this has come under a lot of scrutiny, and we are starting to rethink whether this should be done in some cases or what is the safest way to do it. We'll leave that for another day. The abdominal route has a higher complication rate than the vaginal route, although the overall rate is still low. The hospital stay is generally a little longer, and this is due to pain, need for pain control, difficulty getting up and moving after abdominal incision versus a vaginal incision, and the overall recovery time is usually longer for the patient. So they'll be slower to return to normal activity, normal function after an abdominal case. The next route to talk about is the laparoscopic hysterectomy. This is one that is a relatively new technique, and it is gaining a lot of ground. It's often useful in treatment of an obese patient. Many gynecologists find that it may be the preferred route over the vaginal in cases of pelvic pain. The reason being that with the laparoscopic route, you get to really visualize the entire abdomen and pelvis. You can look for endometriosis, adhesions, or other causes of pain that are extrinsic to the uterus. I'll let you get a good look at the ovaries if there's any questions about that. And it's a procedure that would be easy to combine with other laparoscopic procedures, like, for example, lysis of adhesions, or a laparoscopy that maybe our general surgery colleagues would want to perform at the same time. The laparoscopic hyst is somewhat limited by skill and experience of the surgeon, as are all surgical cases. And some of the same limitations about the size of the uterus might apply, particularly in light of our concern over morcellation. And the complication rate, again, overall low, slightly higher than vaginal, but very close. And the potential advantages which we are starting to see in some studies that are being done, and it'll just take more time with more cases being done to see if this holds true, are decreased post-op pain, shorter stay, and quicker recovery. I mentioned this is a newer technique. Many gynecologists practicing today didn't learn how to do this in residency and had to take time to train later to do it. And that may be the reason that the complication rate is slightly higher when you compare it to vaginal hysterectomy. Now, as time goes on, as more residents are trained to do this, we may see that that complication rate for laparoscopic hysterectomy comes down and approaches or even equals that of the vaginal hysterectomy. And this may be one of our more preferred routes later on. Other things to consider in the laparoscopic hysterectomy are that it is a little more expensive compared to vaginal. And this is just because of the specialized laparoscopy and equipment that is needed. And the procedure takes a little more time. These two things together add to increase the overall cost of the procedure, which may or may not be offset by a shorter hospital stay. Kind of remains to be seen. Contraindications to a laparoscopic case would be really anything that would prevent you from doing laparoscopic cases generally. So an unstable patient due to, say, heavy bleeding or other causes of hemodynamic instability, or a patient who can't have peritoneal insufflation. Either of these would prevent you from doing it laparoscopically. And then finally, the anatomy of the uterus in the patient has to be considered. There have been cases where, say, we place the laparoscope and then we realize once we get in there that the fibroid or adnexal mass or whatever we're going in to try to treat is blocking access to the uterine vasculature. And in those cases, it's probably not safe to proceed with a laparoscopic case, and you need to reconsider whether you can do it potentially vaginally or at that point possibly laparoscopically.